Happy Thursday, everybody. Welcome to another VMR. I was excited to tell you that this would be the first time I would discuss with one of our newer members, but I was very, very happy to see that Simi already got her first rep in with somebody way smarter, kinder than I am with Charmaine on Wednesday. Not this Wednesday, but the previous one. And I'm not surprised. Usually, I get the privilege of introducing folks to the discussing space, but some people have had such tremendous success, community building, doing incredible things, as Simi has done with her first 6 months in CP Solvers, to the point where I bet you everybody knows Simi in this space, both internally because of how much heavy lifting and kindness she exudes in that space, but also externally. Simi has been the source of many bridges between people who are on VMR who really enjoyed VMR and wanted to become part of the academy. And I get secret CIA spying from Simi who's like, oh, check out this person, check out this person. So I'm very, very grateful for all that you're doing, Simi, and excited to celebrate that with discussing today. I'll hand the mic to you to say hello, and then we can introduce everybody else.
Hello, everyone. And Rob, that was such a kind introduction. And I just want to say that I'm very confident today because I'm with Rabih, which means that we will definitely crack this case.
Julia may have other other thoughts about that. Thank you, Simi. Julia, case presentation number 100 million. Actually, what's the number? Do you know?
70.
Say that again.
70.
Seventh. Oh my gosh.
Yeah.
How many have you planned total? Do you know?
Um, that I done. This is the last one, but I
I
have
see.
other like cases that I have to prepare.
Yeah,
So more three or,
I see.
and I can get more. So
Amazing, amazing. Every single time, it's been an absolute treat to discuss your cases. Very, very excited for today's case. I also would love to shout out the two people who are making the logistics happen too. First, hand the mic to Lyra, who is scribing today.
Yeah, hi everyone. My name is Lyra. Um, very excited for the today's session.
And Parisa is on teaching points. Mic to you, Parisa.
Hello, everyone. This is Parisa. I'm doing Teaching Point. So excited for CME discussion. And so I'm happy to be part of Thursday masterclass.
Alrighty, Julia, the mic is yours. Let's have fun this hour.
so let's start. I have a 79-year-old woman who presents to the emergency department with progressive shortness of breath, chest pain described as pleuritic, and increasing orthopnea, now sleeping with 3 pillows for the past 14 days. She also reports paroxysmal nocturnal dyspnea, early satiety, and postprandial fullness. Family members note that over the past months, she has had nausea, vomiting, and poor appetite. And I will stop here.
Excellent. Julia, this is a really, really fascinating start. And thank you for such a clear HPI. So Simi, I'm curious what thoughts you're formulating with this HPI.
Yes, definitely a very rich post, Aliquot. And I'm thinking about the presence of pleuritic chest pain, whether it is central. If it's central, we can think more about pericarditis. And if it is on the sides, we can think about the pleuritis or involvement of pleura. But also we have shortness of breath and the patient also had orthopnea. So that makes me think about cardiopulmonary causes, but also if there is an issue with the diaphragm, either increased pressure in the diaphragm from above or below from conditions like ascites, or there is trauma or a neuromuscular problem here. And as for patients' early fullness and early satiety, I think that this might be something that is going on for quite some time, and maybe that was the shortness of breath or pleuritic pain that caused the patient to present now. And but Rami, I'm not sure that which symptom should we focus
Yeah.
more on. It is pleuritic pain, or is it shortness of breath or orthopnea that you would prioritize for this patient?
I think, Simi, you're illustrating a very powerful phenomenon that happens to people when they learn more. And when you learn more, you have more knowledge and more possibilities, and that can sometimes make it hard to make progress. Because, Simi, if you didn't know so much, you would say this is orthopnea PND. This has to be heart failure. But yet, at the same time, you're entertaining pleurisy, pericarditis, postprandial diseases, and diaphragmatic dysfunction. And that's the challenge of how do you use your knowledge? And I think you're using it very wisely because you're remaining broad, but at the same time, the base rate helps you really make progress. So, of all the things that you just mentioned, diaphragmatic dysfunction, pericarditis, pleuritis, um, which which do you think would be the most common, albeit imperfect, explanation for what might be going on? What do you think?
Yeah, I think that given the patient's orthopnea and how patient is being with below, so I'm more concerned about the patient's heart here, but let's see, I'm thinking
Yeah.
more about failure now.
I agree with you. I think it shows to you the idea of an operating hypothesis. So what happened in my mind, Simi, is very similar to yours. I immediately couldn't help because of how often we see congestive heart failure to have an operating hypothesis that that's actually the working diagnosis here. But then I think it's important, as you did, to acknowledge the things that are relatively unusual. And what's relatively unusual is pleuritic chest pain with heart failure. Not so, not very common. Could we imagine it happening? Sure. Postprandial fullness and early satiety with heart failure? Could I imagine that? Yeah. But it's unusual. And so I think that whenever you have such a common condition that has so much prevalence, you'll realize that the standard deviation of the presentation is so wide that you'd really accept it and see, one, are these clues rather than arguing against heart failure? Are these clues that help you decorate the severity or the cause of the heart failure? And so that's what I'm thinking. There's too much of a theme for congestive heart failure to discard such a common hypothesis, but acknowledging that there are some unusual features that may help us understand, oh, this is maybe bad heart failure, or maybe this is heart failure of an unusual variety. Of course, we may be totally wrong, and she may have diaphragmatic dysfunction. So I'm right there with you. But Simi, if you were to assume that this is heart failure, what other information would be helpful for you to cross the threshold of being more confident that it is in fact heart failure?
Yes, Rabih, I loved how you explained everything. And I think if the patient has JVD on examination, if there is any edema, and if we see any crackles on the examination, that might take us towards pulmonary edema. Also, I think that if the patient is 79, maybe past medical history would help us because maybe the heart failure is already diagnosed and now we have superimposed pericarditis or anything else going on in this patient. So I think definitely getting some more history would be helpful in exam.
Superb. I have nothing to add to that. That's excellent. So as we move forward, let's see what happens to our hypothesis of heart failure. And as you did, let's track the pleuritic chest pain and the GI symptoms to see if we can, how we can attach them. I don't think we can lose sight of them for sure. All right, Julia, mic to you.
So let's move on and try to answer some of your questions. So the patient was hospitalized 1 month earlier for pericardial effusion with new onset heart failure with preserved ejection fraction, profile B. During this prior hospitalization, the patient also reported persistent nausea, vomiting, early satiety, and poor appetite for several weeks. And within this hospitalization, a pericardiocentesis was performed with symptom relief, and she was discharged clinically stable. Since discharge, she reports progressive dyspnea, particularly while lying flat, as well as persistent of these GI symptoms that started, as I mentioned, several weeks before the first admission. So going to the past medical history, she had type 2 diabetes, hypertension, dyslipidemia, this new diagnosed heart failure with preserved ejection fraction. She had a recent left subclavian vein thrombosis in March of this year. Also, the meds include insulin, metformin, simvastatin, furosemide, rivaroxaban, losartan, amlodipine, and omeprazole. Family history is important for daughter had TB 40 years ago, father had TB in childhood, no family history of cancer. Social history, she was a retired rural worker, lives in Brazil, no smoking, alcohol, or illicit drugs, no recent travel, and reveals allergy to dimenhydrinate. And that's the end of the second aliquot.
Wow, Julia, what an intriguing space. Simi, you predicted that the history might be enlightening. How did it help you?
Yes, Rabih, it's been very helpful that we know that there is heart failure, but there is so much more going on as well. Patient also has diabetes, and now that the GI symptoms are still present, so I think that there is something we should also think about. Maybe there's something intraluminal or something pressing on the GI. Also, the patient has diabetes, so sometimes patients with diabetes have gastroparesis as well. So that is something we can think about as well. And given the TB history in daughters, so we should always have it in the back of our mind when we have pericarditis like picture and TB. What do you think, Ram?
Yeah, for sure. I'm right there with you analyzing all those things. I'm curious what you did with the previous hospitalization. How did that change your calculus?
Yes, Rabbi, I think that shows that this is not something that is new for this
Right.
patient. Maybe
Right.
that's going on for a long time.
Mm.
And now maybe the patient presented because the patient had very poor appetite, or whether it was just the shortness of breath that was debilitating for this patient, but I'm not sure how to tie it in exactly.
Yeah, I think it's an interesting space because I think it readily explains. You know, when you first said, I want to know if the pleuritic chest pain is central or lateral, implying pericardial or pleural. I think it has now gotten a lot more momentum that your hypothesis that this is an unusual form of heart failure has borne fruit because it seems that she had pericardial disease as the cause of her heart failure. So I don't think we need to track the pleuritic chest pain anymore. It's probably going to be explained by a recurrent pericardial effusion. So the question now I think becomes, well, what causes pericardial effusions and how do we begin to dissect that problem? So maybe I'll hand the mic to you just to get your preliminary thoughts about pericardial effusion in general, and we can try to see how we can tailor it to this case. What do you think?
I think Orbit can be secondary to infections like TB. They cause pericarditis and then complicated by development of infusions. Sometimes patients have MI and then complicated by
Right.
development of infusions. And sometimes patients have some underlying autoimmune disease that can contribute.
Yeah.
And sometimes we can have malignancies,
Yeah.
and TB is still very, very recent for me in this case. What do you think, Robin?
Yeah, I think you outlined all the categories, and what I'm going to do for you is to give you a relative number to assign weight to each of them. Unfortunately, Simi, the vast majority of people, around 70%, have pericarditis for no clear etiology. We never find out what they have, but there are two rules about those people. One is at the time of the pericardial effusion, they have nothing else going on, and two, they never recur. She has broken both those rules because at the time of her pericardial effusion, she was diagnosed recently with a left subclavian thrombosis. That's unusual enough that it would be very, very atypical for her to have an isolated pericardial effusion simultaneous. The other rule she's broken, of course, is she's not had a monophasic course. She's recurred. So that's when we skip and think about your categories. But most of the time, Simi, you don't have to think about pericardial effusion. If you remember the academy session that I presented to you all of the young man who had pericard. I don't. You're almost always there, so I imagine you were there. The young man who had pericarditis, no reason, idiopathic, and he got better. Same story here, but that doesn't apply because he didn't have any other features. She does, and he didn't recur. She did. That's when we step over to the secondary causes. And let me tell you that the vast majority of secondary causes are cancer. Vast majority. There is the probability of TB, and maybe my numbers are skewed and maybe different than your numbers in Pakistan because of the relative prevalence of TB. But even in TB endemic regions, cancer looms large. Of course, then there are autoimmune diseases naturally, and some very interesting phenomena called post-injury pericarditis, which you touched on. The injury can be a myocardial infarction or recent surgery, and that injury is that's called post-injury disease. And the classic historical presentation is called Dressler syndrome, which you probably heard on first aid or by studying for the boards. So I think the operating hypothesis here, Simi, is that this is a recurrent pericardial disease, and we have to skip over idiopathic and then now think primarily, is this malignancy or tuberculosis? So you already mentioned why you might be worried about TB given the exposure in a close family member. What clues do you have for the possibility of a malignancy here?
Well, when a person has thrombosis and there is no obvious reason, so malignancy is something we can think about, but also the patient's early satiety and that the patient has not been able to eat well. So that is also worrisome for me in this patient.
Absolutely. I completely agree with you. I think that if you look at the whiteboard now, it is screaming cancer. The base rate of secondary pericardial disease, a spontaneous thrombosis. And I will also add, Simi, the location of the thrombosis is key. Many peripheral deep venous thrombosis are unexplained, and the major risk factor for them is age. So you'll notice that after the age of 50, me, you, hopefully we're still discussing at the age of 50, might get a thrombosis with no real explanation. But when you have a central thrombosis defined as more proximal than the knees and the elbows, the probability of a secondary cause is very high. And the vast majority of secondary causes is cancer. So this is screaming cancer. The question is, as you said, how do we find out? Make progress? Of course, cancer is a radiographic diagnosis in the vast majority of people, followed by a biopsy, right? So if you think it's cancer, you have to get a radiographic assessment of this person. And the question is it in the GI tract, as you've alluded to? And those of you who have a tremendous momentum towards this has to be cancer in the GI tract, why else would you have early satiety and nausea and postprandial fullness? The counter hypothesis would be that this is all GI edema and ascites. And it turns out that patients with pericardial heart failure have a disproportionate amount of abdominal edema and ascites just from the heart failure. It's a term called ascites precox, Praecox, and it shows that in patients with pericardial disease, they have both lymphatic obstruction and right atrial obstruction that disproportionately causes intra-abdominal congestion in the stomach and in the form of ascites. So we may be led wisely to analyze her stomach based on her symptoms, but if we don't find anything, I think it's plausible that her GI symptoms are the result of ascites precox. The biggest counter argument, Simi, is that her GI symptoms did not improve with drainage of the pericardial effusion, and that gives me pause for sure. But I just wanted to put it out there that not everyone who has postprandial fullness plus heart failure has cancer. Ascites precox is a very common and satisfactory explanation for that. So you wanted the exam, and why don't we hand the mic to Julia to see what she has next?
So the patient arrived with some respiratory decline and was placed on oxygen cannula for liters. So these vital signs are based on with oxygen cannula. So the blood pressure 120/70, heart rate 110, respiratory rate normal at 18, saturating 89 on 4 liters, and afebrile. General, this patient appeared weak and pale but oriented. On the lungs, we heard bilateral crackles and decreased breath sounds at lung bases. On the heart, normal sounds, no DVD, no murmurs, no pericardial rub. On the abdomen is globose, but soft, non-tender, and no organomegaly. On the extremity, there is some mild edema in both legs, but no calf tenderness, and neurologically normal. On the ECG, sinus rhythm, no blocks or acute ischemia. We also had the ABG on 4 liters of oxygen that reveal a pH of 7.52, PCO2 of 38, PO2 of 49, bicarb of 26, and saturating of 89. This PO2 is low. Sometimes we have the venous blood gas. That's why the PO2 is so low in this case. And also I had the initial labs. So hemoglobin of 11, hematocrit of 33, white blood cell count of 80 with neutrophil predominance, platelets of 96, creatinine of 1.3, urea 36, sodium normal, potassium 30.1, glucose 54, LGA 330, ESR 15, and CRP 3.57. And that's the end of the third aliquot.
Fascinating. Wow, there's a lot to discuss here. Maybe we can focus on the physical exam, Simi. I'm curious, what did you make of the vital signs?
Probably the BP is not elevated in this patient. However, we did have a history of hypertension, but low oxygen saturation makes me think that we should also think about pulmonary causes. Also, Mark mentioned in the chat that pulmonary hypertension is something that can also present like that. So we should think about cardiac, but also pulmonary causes as well. And as for the bilateral crackles and decreased breath sounds, I think that is not something unexpected for this patient, but we do not have a JVD and no lower extremity edema. So I think the patient is not in decompensated heart failure at this point. And and that's what I'm thinking about. And Rabih, please help us make further progress.
Yeah, I think it's very difficult because if you just started with this case, right, Simi, and just with this exam, and you saw there's no JVD, there's no and there's minimal edema, you would really disregard the hypothesis that she has congestive heart failure. And of course, the lack of JVD and the lack of edema reduce the probability of heart failure, but it's a question of, well, what was the pretest probability? Was it high or low? And you'll see so much variability in how people report and do the JVD that you can't lean on that a lot to dismiss heart failure. And the same is true with edema. As we just talked about, patients with pericardial disease will disproportionately hide their fluid in their belly, not in their legs. So you could easily say, I'm going to keep stubborn about my hypothesis that this is pericardial disease because the JVD is notoriously unreliable and the patient may not be hiding the fluid in their legs, they may hide it in their belly. But I think at the same time, you have to widen your gaze and say, well, maybe it is something else. Maybe I haven't appreciated that and there is something else going on. And so I think the way you would make progress is to analyze the rest of the data before you. And I think the hypoxemia is very, very interesting, as is the sinus tachycardia. And I say that because sinus tachycardia is a very uncommon finding in patients with acute decompensated heart failure and should really prioritize obstructive causes like pericardial disease. So for me, the exam gave me vertigo. I first said, oh, no JVD, no lower extremity edema. Maybe not heart failure, but my pretest probability was pretty high. So I'm stubborn. As my dad used to say, it's the most stubborn child ever. It's still true. Uh, although I think I know somebody a little bit more stubborn than me who's barking occasionally. Anyway, I digress. So yeah, here see me, I'm back and forth, back and forth, back and forth. So I think we should broaden our gaze, but let's not let go of the heart failure hypothesis. It can fool us. Oh, what did you think of the labs?
Yes, probably we have bicytopenia here, having low platelets and low hemoglobin. So you have taught us that when we have bicytopenia, we can think of conditions like TTP, also certain infections and malignancies can also cause that. And we have a low we have neutrophilic predominance, but the BBC overall is not that high. So I'm not sure if we can think about was under pressure here because we think of it when we have neutrophilic predominance, but WBC level is not that high. And as for what to make about the ABG, I'm not sure of that. And we also have some hypokalemia here, and glucose level is low. That might be due to the fact that the patient is not eating well, has been having early satiety and loss of appetite. So that's what I'm thinking about it. What do you think, Rabih? And calcium, was it normal or was it elevated? Julia, please can you clarify that?
Yeah, I don't know. Julia, is that ionized calcium high or normal? Do you remember?
It's normal.
Normal.
Yeah, the units is between like 1 point something
Yeah.
to 1.16 to 1.31. So it's like a little bit low, but yeah,
Yeah.
it's normal. It's actually normal. Yeah.
Yeah. Yeah, I'm right there with you. I think Simi, the labs say this is not regular old shortness of breath, right? How many people with shortness of breath have a platelet count of 96 and a glucose of 54? So what this would do for me in real life is to tell me, hey, I'm dealing with something very unusual. And the difference between this case and most cases featuring hematological diseases, hematological perturbances, is a very simple concept about focality. Most hematological perturbances are diffusely in the blood and cause widespread symptoms from head to toe. Acute leukemia, TTP, headache, nausea, not feeling good. This person has hematological perturbances with very focal problems. A focal problem in the lung, hypoxemia, and a focal problem in the upper GI tract. Most hematological diseases have little to no extravascular fingerprint. This person suggests by their symptoms that they have an extravascular fingerprint, rendering their hematological perturbances uncommon and intriguing. So before I solved anything, I would make sure we get a peripheral smear, as you talked about. But I'm really curious to see what their extravascular fingerprint is. And I wouldn't be surprised if that extravascular fingerprint is mass forming, i.e. that there's something that we can visualize in a collection. And I think solving that plus hematological perturbances is very different than solving diffuse hematological disease. So I'm really, really curious what the imaging is going to show. And I think it's going to be very important to scrutinize the pulmonary imaging to try to see, is this pulmonary edema or is this a mimic of pulmonary edema or both at the same time? So I would be looking at this and I'd be like, I've seen hundreds of patients with heart failure. Almost none of them have a platelet count of 96 and a glucose of 54. So maybe it's not heart failure. Or maybe it's heart failure with a little bit of a twist. All right, Julia. Mike to you for your upcoming twists.
So they did bedside ultrasound that did reveal pericardial fluid again. They punctured again and showed a non-purulent, so glucose of 86, protein of 5, and 84% of lymphocytes. Given this lymphocyte predominant and in the tuberculosis endemic area, TB was considered, and they did the bar and cultures that was negative. And on the day 2 of admission, she clinically deteriorated with hypoxia, raising concern for pneumonia or superimposed infection. So we started with empiric antibiotics for sepsis protocol while waiting for the imaging. And we did a CT chest that showed no evidence of pulmonary embolism, reveal bilateral pleural effusion more in the right, bronchial wall thickening, reticular opacities, and ground glass infiltrates, and also cardiomegaly. We also did a TTE that showed concentric left ventricular hypertrophy with a left ventricular ejection fraction of 58, also persistent pericardial effusion, and moderate pulmonary hypertension. And I will stop here, and the next one will review the diagnosis.
Dun, dun, dun. Okay, Simi. You said hopefully it's an easy case. I don't think so. What I would propose is that we do a nice 5-minute breakout room to really get the juices flowing from everybody here. So let me pause the recording. Okay. All right, Simi, you were with some very, very smart people. What did you all talk about?
Yes, probably I think it was a great idea to have breakout rooms, and I was help me further. So we were thinking that we do not have the immune status of this patient yet, so we should definitely get HIV test for this. And Anne-Marie and Hans also mentioned that we have lymphocytic predominance, so maybe we can think about TB, but also other fungal infections that are endemic to the area, if histoplasmosis or paracoccidiomycosis is also endemic to the area. And other than that, the patient also has left ventricular hypertrophy, and I was attributing it to hypertension. But Austin said that there could be more to that, which was a wonderful thought as well. And please help me further, Rabih, relying on you completely.
No, not at all. I think that this case is a very, very difficult one because we get so fixated on the patient's symptoms, and you can see that Julia's team is able to make a diagnosis without even getting imaging of her belly, or at least make a lot of progress. And I think that in real life can be very, very difficult because what is happening in her abdomen may be a powerful clue to what's going on. And so our task, which is a task I'm very grateful for Julia giving us, is try to predict. We have to guess what her abdominal symptoms are, right? Because we have so much clarity here, but we have no idea what's happening below. And that's, I think, making this task a fun challenge. And so, how can we get more juice out of it? I think the first thing to discuss out loud for everybody on YouTube to also reflect with us is, what do we think about TB? Because Julia told us, hey, all the TB studies are negative. Has TB been eliminated in your mind, or can you think of reasons why it still belongs on the DDX?
Yeah, I think it can be sometimes very challenging to diagnose it. So it is still in the back of my mind. But you've noticed that we have lymphocytes. We can see whether they are activated by seeing LDH level and AD level. So do you think that will help us make some progress in this case? And what do you think? Can we still consider it TB, or should we think about something else?
Yeah, I think that it's probably helpful for all of us to remember that TB doesn't infect the fluid, be it the pleural fluid or the pericardial fluid or the acidic fluid. So the infection isn't there. It infects the lining of the fluid. So it infects the visceral pleura, the visceral pericardium, and the visceral peritoneum, which means that the majority of the organism is actually lining those surfaces, not in the fluid. And so you'll never, ever be able to rule out tuberculosis by sending any fluid, and it's negative, be it sputum, bronchoalveolar lavage, pulmonary, pleura, meningeal. It's not a fluid infection. It's the serosal surface next to it. So if you do a lung biopsy, you'll have a much higher yield of TB. If you do pleural biopsy or pericardial biopsy, so TB is very much in the calculus here. And I think that's the tension. Is it TB or is it cancer? And you cannot say that simply because the TB test is negative that it has to be cancer or some other infectious process. But I think, Simi, we can get a lot of juice out of analyzing the echo. So this is a question that I don't think many graduating residents would confidently know the answer to. But I think it's a question that you and I should start. So I don't anticipate you to know the answer fully, but I'm curious what you and I can deduce together. So, what do you expect the pulmonary pressure to be in somebody with a pericardial effusion? Now think that through.
Oh, yeah, I think that when we have effusion, there can be pressure on the heart and on the pulmonary vasculature. So maybe the pressure would be high. And we do have moderate pulmonary hypertension here. So that's what I'm thinking, but would love
Yeah.
to learn from.
Yeah. So, oh, stay unmuted, my friend. Let's talk. Okay. So you were thinking creatively, and maybe I can you can correct me if I'm guessing how your thinking is wrong. So you're thinking the pericardial effusion puts pressure on the pulmonary artery, and that pressure increases the pulmonary pressure. Is that what you're thinking, or maybe you can tweak what I just said?
Yes, Robbie, that was what I'm thinking,
Yeah,
but
sure.
maybe there's so much pressure that the blood cannot move forward. So if the blood is not moving, maybe the pressure cannot be that high.
Uh,
I'm not sure.
yeah. No, let me give you one piece of anatomical emphasis, which is the pericardium does not loop around the pulmonary artery. The pulmonary artery exits the heart, and so the pericardial pressure is not transmitted to the pulmonary artery. And what you said is true. What is the pericardial pressure transmitted to? It's transmitted to the right atrium and the right ventricle. And it collapses the right atrium and the right ventricle to some degree. Whether that degree is criteria for tamponade is just a manifestation of how bad it is. But the pulmonary pressure in a patient with a pericardial effusion is usually low, no different than a patient with systemic arterial pressure. Both the aorta and the pulmonary artery are both getting less blood, and the patient's getting at risk of hypotension on the pulmonary artery side and the aorta side. So when you see that a patient with a pericardial effusion has pulmonary hypertension, oof, that means their pulmonary artery pressure must be so high that even though the RV and the RA are having less blood from the pericardial effusion, it's still high. So now we have a profound clue. But I'll just tell you very simply, Seeme, do you associate tuberculosis with pulmonary hypertension just reflexively? Is that a strong association that you have?
Oh, Robbie, I don't. Maybe I'm wrong, but I
No,
don't
no, you're
usually.
not wrong. You're not wrong. Do you associate cancer with pulmonary hypertension?
Yes, very likely. Sounds likely.
Yeah. So now you have pulmonary hypertension, pericardial effusion, and a spontaneous thrombosis. This case is screaming cancer even more loudly. And the question really in my mind is what cancer? And I think breast cancers are the most common cancers to affect non-smoking older women. So that has to be considered based on the base rate. What would be characteristic is that this patient has a metastatic gastric cancer. Metastatic gastric cancer notoriously causes rapidly progressive pulmonary hypertension associated with a DIC-like profile, including thrombocytopenia and anemia. So that's definitely something on my mind. The other really hypercoagulable cancer that does this is ovarian cancer, though most patients with metastatic ovarian cancer typically have abdominal distension from their ascites or their large tumor. So I really worry this person has cancer, and I think that we might get lucky and find it in the pericardial fluid on cytology. But yeah, I think the next step is to really, really look very closely for cancer. Even though, as you said from the get-go, this could be an unusual manifestation of TB or an unusual manifestation of an endemic mycosis, but I think those conditions do not typically result in pulmonary hypertension, let alone pulmonary hypertension sufficient enough and severe enough to power through a pericardial effusion. Let's see what Julie has in store, and then we can reflect on it afterwards.
So, as you amazing discussion. So this patient, due to this red flag GI symptoms in an elderly patient, an endoscopy was performed in the first hospitalization. The endoscopy revealed a gastric ulcer, which was biopsied and sent to the lab. But unfortunately, for some reason that we don't know why, the patient just received the diagnosis in this hospitalization. Maybe no one, like anyone, checked the biopsy or took like a month for the biopsy came back. But the pathology came back as a poorly differentiated diffuse type gastric adenocarcinoma rich in signet ring cells. And the final diagnosis was metastatic gastric adenocarcinoma with pericardial and thoropulmonary carcinomatosis. And although peritoneal carcinomatosis is most common in these types of cancer, signet ring gastric cancer can also see the pleura and pericardium, causing these recurrent serial effusions. So that was the case. I will let you discuss a little bit, and then I have some teaching points.
Yeah, Julia, this was a really, really very enlightening case. Um, I think that you're really a master storyteller because you could have told us about the EGD early on in the case. But can you imagine how much less learning we would have had if you had given us that information? And we would have probably been so focused on that. So it is like an artist painting a story to reveal that information, even though it was done before, later. That's I think the power of practicing your presentations is because this is the kind of storytelling that you're going to be doing when you're an intern on the wards, is you're going to be telling a story to your attending and your resident, and you want to engage them, have them be listening to you, not distracted by their phone or other things, and you have mastered that skill. So I can tell already that the residents and attendings who will work with you will be very, very surprised by how advanced your skill set is. And same to Seeme. I think the ability to discuss this is a NAJM CPS case, Seeme. This is like super rare, very difficult diagnosis, and you stood firm the whole time. I'm curious, what are your reflections? How are you thinking about this case in its entirety?
Bobby, I think that it was just beautifully presented, and I'm just mind blown by how you explained everything and just love discussing with you.
Yeah, Seeme, I think that ultimately there's a really powerful pattern here, and I think the only way you can explain it clearly is if you've seen it and thought about it before. Nobody was born with a magic wand to be like, you should be able to explain metastatic gastric cancer. You pick it up along the way. But there are many different angles to approach this case. I'll just arm you with one final one now that we know what the diagnosis is, which is the combination of pulmonary hypertension and ground glass opacities. So we think of pulmonary hypertension on a class from 1 to 5, with the idea being that 1 is a pulmonary artery disease, 2 is heart disease, 3 is lung disease, 4 is chronic thromboembolic disease, and 5 is a mixture of many different mechanisms. So what does the presence of ground glass opacities and reticular opacities, how does that influence the analysis of pulmonary hypertension? And the most common cause of pulmonary hypertension and reticular opacities is left-sided heart failure and pulmonary edema. However, we know that this person's LV ejection fraction is normal, and the probability of her having left-sided heart failure is pretty low. The temptation would be that she must have pulmonary disease or class 3 heart failure, class 3 pulmonary hypertension, because she has something in her lung. But actually, that's incorrect. The most common cause of class 3 pulmonary hypertension, that is intrapulmonary, are airway diseases, not alveolar diseases. So chronic obstructive pulmonary disease, COPD, and obstructive sleep apnea are the most common. The one alveolar disease is interstitial lung disease, but interstitial lung disease does not develop on the order of weeks. And if it did, it would not have enough time to develop pulmonary hypertension. So you're seeing that ultimately class 3 or pulmonary cause of intrapulmonary causes of pulmonary hypertension are always chronic, can't be acute. So class 2 is gone because the LVEF is normal. Class 3 is gone because the disease isn't chronic. Class 4 is gone because there's no PE. Class 1. And so you may ask, wait, how can class 1, which is supposed to be a disease of the pulmonary artery, cause ground glass opacities? And for that, I will share in the Academy session today at 11:30. So instead of the case, I'll discuss with you all. It's a really, really important case. For those of you who want to learn that, you know what to do. Let's hear your cases, and hopefully hang out with you more. Sorry, I'm distracted by the doggy prancing. But I will say here the CT plus the pulmonary hypertension really allows you to make a lot of progress. But ultimately, I think what you said earlier, Seeme, is a very powerful thing. Spontaneous thrombosis, cancer. And don't let that go. It's a very, very powerful clue. Julia, maybe we can hand the mic to you for your reflections, and then we can hear from Parisa about her teaching.
Yeah, so this patient had this diagnosis of cancer. The first thing is what Vinny just mentioned in the chat, that for some reason nobody looked from the biopsy. This is something that we have to be careful when we send something to the lab, some test. We have to be careful to look for the results, because this could affect the patient's life. And then some key points about this gastric adenocarcinoma. This was a diffuse type Bormann 2 that is high propensity for early dissemination. The most common dissemination is to the peritoneum, but can disseminate to lymph nodes, liver, rarely can go to pleura, lungs, and pericardium, leading to carcinomatosis. And also some clues to consider malignancy, as you brilliant discussion here. So unexplained pericardial or pleural effusion, negative infectious and autoimmune workup, also systemic symptoms, early society, weight loss, and the cytology of lymphocytes, predominant, non-purulent. So all of this goes toward malignancy. So that's it. Thank you so much for letting me present this case.
Another legendary case, Julia. Really, really outstanding and a great teaching. Both about the practicalities of not following up tests and also a really cool diagnosis. Thank you. All right, Parisa, take it away.
It was an amazing case, Julia, and wonderful discussion, Simi. I learned a lot. We started from a patient who presented with progressive shortness of breath, pleuritic chest pain, and increasing orthopnea. And Simi taught us that we need to frame the pleuritic chest pain as a central pericarditis versus peripheral as pleuritis. Considering the base rate, when somebody is presenting with shortness of breath and orthopnea, the first thing we are considering is congestive heart failure. And usually the physical examination finding like JVD, edema, and crackle, lung crackle are helping us to frame our working diagnosis, but we still need to remain open to unusual features of heart failure, because pleuritic chest pain is uncommon presentation in classic heart failure. We also talked about cardiac effusion etiology. We learned that most common causes are idiopathic categories. This category of the patient are usually presenting they are just have this presentation once, and there is no other clue in their presentation. We also touch base on the secondary causes. The most common cause in that arm are cancers, and then TB, autoimmune causes, and post-injury, which is coming due to irritation of the pericardium, MI, surgery, and the famous syndrome is Dressler syndrome. The clue toward malignancy in this patient were secondary presentation of the pericarditis, a spontaneous thrombosis the patient have, and the location of his thrombosis, and the early satiety this patient have. Early satiety was some kind of our branching point, because we were thinking about primary GI cancers versus edema due to the heart failure. We learned about some entity, ascites precox, in pericardial disease, abdominal congestion. It's accompanied with GI syndrome, but GI symptoms should improve after pericardial effusion drainage. We also categorize peripheral thrombosis and central thrombosis. Peripheral are usually presenting, this is the place, the location is important. The location is below the knees and elbows, and these category of the patient are age over 50, and this is the major risk factor. On the other side are central thrombosis, which are more proximal, and they are much likely to be secondary. Our patient had a sinus tachycardia, which is uncommon presentation in acute decompensated heart failure, and we need to prioritize obstructive causes like pericarditis. The other unusual presentation our patient had was thrombocytopenia. We learned that hematologic presentation usually have widespread presentation. When we have the focal presentation like hypoxemia, we need to pay attention to extravascular fingerprints. We need to obtain PBS, and we also need to think about mass-forming causes and get the imaging. Our patient has lymphocytic predominancy. We thought about the TB causes and the endemic fungal, and we learned that the TB usually does not infect the fluid, but it will infect the visceral like pleura, pericardium, and we are not able to usually rule out the TB based on the fluid only, and we require to obtain the biopsy. We also touched base of the pulmonary pressure findings on the echo. We learned that the pericardium does not encase pulmonary arteries, so the pulmonary pressure does not directly affect by the pulmonary artery involvement. And when the pulmonary hypertension is high in this setting, we need to think about the other causes. The high-risk cancer in which are presenting with pulmonary hypertension are breast cancer, metastatic gastric cancer, and ovarian cancer. Just summarizing our problem representation, we had a patient who was coming with pulmonary hypertension, GGO, pericardial effusion, and unexplained thrombosis, which was so unusual to have this presentation. And the first thing we need to consider is malignancy. And we also learned that the interstitial lung disease is the main alveolar cause of the pulmonary hypertension, and it is one of the places that tempo is the queen, because which is developing over the months. It's not just developing suddenly. Thank you, everyone. It was an amazing session.
I think the only thing that is queen is you of teaching points, my friend. That was absolutely superb, master class. I don't think you forgot a single teaching point we made. Thank you. That was a true delight. What an hour with three outstanding people in medicine. It was a real treat. I hope you guys enjoyed it as much as I did. See you all later. Bye.